Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearScope endoscope. Here we have a patient who attended with really narrow entrances to both ears. This is their left ear, and laterally at least the wax is quite soft. They've been using some drops, I believe, and what I'm removing now is some dead skin. Now you can notice there is some humidity within the ear canal, no doubt because of how narrow the entrance is. And this causes some fogging, some misting of the lens of the endoscope. So all the condensation is on the tip of the endoscope. Now, as soon as you enter with the suction probe, that eliminates all the fogging and misting. However, if we just left the endoscope there for about 5 or 10 seconds, it should automatically demist. So to gain access deeper in the ear, I'm using, I think this is a 17 gauge suction tip. And I'm just mopping up some of this softer wax and dead skin caused by the oil. But this patient's got some dead skin lining particularly the roof of their eardrum, so the superior aspect. And they've got quite a severe retraction posteriorly. In fact, this eardrum is so sucked in that it's draped over the head of the stapes. So the stapes is the third of the 3 middle ear bones. It's the smallest bone in the body. And if you look on screen now at 12 o'clock, you'll see this spherical bony protrusion, and the eardrum is sucked around that. So that's the head of the stapes. That normally attaches itself to the incus, so that's the second of the 3 bones, also known as the anvil. And when that's draped over, it typically signifies that the incus bone is actually eroded, and it could be eroded in 2 different ways. When the eardrum is sucked in as much as it is, it wraps itself around the bones and it almost suffocates the bone. So all the blood capillaries there are constricted. So the incus no longer receives the blood that it requires and all the nutrients supplied by the blood. So it decays, it erodes and dies away. It can also be due to a process called bony remodeling. So again, when the eardrum is sucked in, it initiates specialized bone cells sitting on the surface of the bone called osteoclasts. And osteoclasts break down bone into its minerals and tissues and redistributes it into the bloodstream so new bone can be formed in other parts of the body. Another potential reason, it could be that this patient had a middle ear infection, which is very likely because they've got obviously a blocked eustachian tube. So the eustachian tube is the pressure equalizing tube. It tries to regulate the air pressure in the middle ear cavity, so the space behind the eardrum, so it's equal or thereabouts to the air pressure in the ear canal. And if the eustachian tube is blocked, it can lead to infections. Because they've got this retracted eardrum, not only posteriorly but also in the attic region, that's why there's a lot of skin forming there. So I wanted to remove that just to make sure there's no middle ear cholesteatoma, which is a invasive dead skin cyst that can potentially be fatal if left untreated. They have got this skin here. Now, this skin is where actually the eardrum should be. And it's attached to the annulus. So the annulus is some fibrocartilage tissue surrounding the eardrum. It almost pulls the eardrum up against the eardrum to make the eardrum taut. And that skin which I left because it started to clarinet. But that's where the eardrum should have been. But you could see the eardrum it was retracted, it was sucked inwards, way beyond that piece of skin. So we're just moving on now to their right side. Again, the entrance is extremely narrow. Now, laterally there's a lot of dead skin, a bit of wax, but they have got an infection in this ear. There's a lot of debris and accumulation of keratin. They've also got a phenomenon known as an autoatticotomy, which I'll explain what that is. And they have got some erosion of the floor of the bony part of the ear canal. Now, there was no visible ulceration, so the skin was still lining the underlying bone, so the underlying bone wasn't exposed. I'm not sure whether this could be pressure necrosis. Sometimes when you get a buildup of wax or dead skin and it compresses against the canal, almost similar to a keratosis obturans, but the pressure can cause some erosion, but you normally get some ulceration there. Could be a condition called benign osteonecrosis. That's where, due to low blood flow to the ear canal, particularly the floor of the ear canal, it doesn't receive all the blood it needs, so the bone is starved of all the oxygen and nutrients that it needs, and it leads to a decaying of the bone, a breaking down to necrosis, so decaying of the bone, and sequestration, that's separation of the bone. But it could also potentially be early stage an external auditory canal cholesteatoma. That's when you get an invasive dead skin cyst forming in the ear canal. At an early stage, you may not necessarily see an ulceration, so the skin is still intact, but that could develop potentially. Now, this infection has probably been there for a while as well, because I saw this patient back, I think, about 6 months ago, and I referred the patient to their GP because I suspected a fungal infection, some otomycosis. On that occasion, I could see some fungal spores, some hyphae. So I asked the patient today what happened after the referral. So upon my recommendation, a swab was taken, but it came back clear. I suspect the swab just wasn't inserted deep enough in the ear canal because of how narrow the ear canal is. So the results came back saying that there was no infection. So if the swab doesn't go beyond this point, it's not going to pick up really any high levels of fungi or bacteria. So showed the patient and they came with attended with their son the video, so they're fully aware that there is an infection here and there's all this debris. But I have recommended I've asked the GP to refer onwards to ENT, and if they wish to go privately, I've given some details of a local colleague. So this patient did travel a fair distance, but I know a local ENT in their area. And the reason for that is not only to get on top of this infection, but also because of these erosions, I just want to make sure there's no early stage external auditory canal cholesteatoma. I suspect there's not. But this patient has got an autoatecotomy. It was there previously as well. So this, because it's infected, we just don't want that infection to accumulate in this autoatecotomy. So an autoatecotomy is when the top part, the roof of the ear canal near the eardrum is eroded. So it's in a region called the scutum, and that's normally secondary to a middle ear cholesteatoma. Now, we know this patient potentially has a blocked eustachian tube in their right ear because they have in their left, and a middle ear cholesteatoma is typically secondary to a blocked eustachian tube. So when the eustachian tube is not ventilating the middle ear cavity, the eardrum gets sucked inwards, particularly at the top part of the eardrum, the pars flaccida region, the attic region, because the fibrous layer of the eardrum in that region of the eardrum compared to the rest of the eardrum, the pars tensor, is less organized. So it makes the pars flaccida more flexible as opposed to the pars tensor, which is the main body of the eardrum. So the pars flaccida gets sucked in, and then dead skin, just like in the left side when I was retrieving that dead skin from the roof of the eardrum, it can't self-migrate, it accumulates in that retraction pocket, and you then have a dead skin cyst that forms, and this dead skin cyst releases proteolytic lysosomal enzymes, which basically start to invade and digest and break down tissue, bone, which can lead to bone death of the scutum region. And then the cholesteatoma then grows inwards into the middle ear cavity. It can grow upwards towards the brain. It can cause a brain abscess, potentially meningitis. Potentially it could be life-threatening, as I mentioned earlier. Now, the autoatecotomy we know it's an autoatechotomy because this patient has never previously undergone ear surgery. So it's one of the questions that we ask. So that bone has therefore eroded automatically, hence the name, an autoatechotomy. But at the moment, we can't really see much. It's just all this debris. So this is just some debris and keratin on the eardrum. I'm just going to use the suction tip to bring a big bulk of this away. Now, spoiler alert, there's going to be some dead skin, still lining some of the ear canal. There's, particularly on the anterior canal wall, it's found it very difficult to gain access to the right-hand side of the ear canal, given how narrow the outer half of the ear canal is. Once you get through the outer half, the ear canal is more or less a normal shape, but the narrowing of the outer half does make it sometimes more difficult to gain accessibility. I did actually use or examine the ear using the ENT microscope and the wax scope, which both use a specular, but you can't get the specular in deep enough to widen this narrowing, because it's this narrow portion of the ear canal, it's probably half of the ear canal, and most speculars only go up to about a third of the way in, maybe a little bit more. So whenever I see an ear like this, it always concerns me the base of the ear canal. You've got all this macerated skin, you've got this debris, accumulated keratin, so we need to clear this. I want to see what's underneath, because this is a hot spot for an external auditory canal cholesteatoma. So we're just going to spend quite a lot of time now just delicately just removing as much debris as possible. I'm alternating between the 16 gauge, the 18 gauge and the 17 gauge in this procedure in the right ear. Now, this patient, just check their age. So they're in the late 80s. So we just got to be wary of how comfortable they are. They had a walking stick as well, so the reason why I mentioned that, the orientation of the ear is probably somewhat different at this stage to normal. So they've got their head tilted back, and for that reason, the top part of the eardrum is actually facing west as opposed to north. Now, I'm not quite sure when, but during the course of the remainder of the video, this patient just sat back further on their chair to get comfortable and just leant their head forwards a little bit. I just asked them to get themselves in a comfortable position, and I'll try and work around them. And you'll see the eardrum then facing more north as opposed to west. The challenge here is you just don't know how dense and how thick this layer of squamous tissue is. So I'm just going to glide over the top. If we penetrate and poke, I could hit the bony part of the ear canal, which would be really uncomfortable for them. And because we're using such a fine suction tip, it kept blocking the tube. Now, to the right, when I just remove that portion, you can see it's quite yellowy there. And sometimes dead, diseased bone can have this appearance. So again, I'm just going to be careful, but it actually wasn't any exposed bone. It was just keratinous tissue. So keratin is a protein that's found in dead skin cells, the epidermis layer of skin. It's also found in our fingernails, and our hair strands. And it has several properties. Keratin is good at reflecting away harmful UV sun rays. It's also hydrophobic, so it helps to repel water. And it adds rigidity to the outer layer of skin, the epidermis layer of skin. Now, the epidermis layer of skin is exposed to the environment around us, so the keratin helps to strengthen that most superficial layer of skin. Now, again, initially I just thought this could possibly be in some exposed bone, but because we just glided over the top, I could feel it was soft tissue. So the eardrum is somewhat now almost fully visible. again, I'm just approaching this very cautiously because I just don't know how thick this layer is. Now that I've peeled some of it, I've got a better idea of where I can place that suction tip. You can see it's quite a thick layer of dead skin. And we can see the underlying ear canal as well. Now this skin that I'm peeling, it can be quite adhesive. It's quite a thick blanket, so I am using a lot of pressure as I'm going up, trying to peel this away. I think this is the 18 gauge at the moment. But each time I'm removing debris, I'm less suspicious of an external auditory canal cholesteatoma. It doesn't mean that this patient hasn't got it. I don't think they have. If they have, it's really, really early stage. They may have had one previously, causing this erosion at the floor of the ear canal. But we know this ear has been infected for a while. It's interesting because I had received quite a snotty letter via email from a local GP. I think it was a couple of weeks ago. And it was quite frustrating because the patient that attended, it's the first time I've seen the patient, and they were explaining to me that they, a few years ago, suffered from a really bad ear infection, and according to the patient, it was misdiagnosed. They were diagnosed with an outer ear infection, so otitis externa, but in fact they had otitis media. And the infection was persistent, it was almost for about a year, and it came to the point where the side of the head began to swell up, and at that stage the patient went to hospital and they were treated for the infection at the hospital. So this patient wasn't really happy with their surgery, and at the time everything was eventually resolved, and they had some symptoms developed, so they came to see me a few weeks ago, and I can't remember exactly what I discovered. I don't think it was anything sinister per se. I think I'm trying to remember, hence the pause, but in fact, whilst you're watching, let me see if I can get up their letter to find out exactly why I referred them. So just bear with me. I think I remember the patient's name. It's not that one. It must be that one. Yeah, so I can actually summarise I've got the information on the letter. So they saw me about a month ago. Prior to that, in 2022, they developed a left-sided ear infection initially. It was treated with both topical and oral antibiotics. So the oral antibiotics would have helped with a middle ear infection. If it was a bacterial infection, it may have been viral. However, they then developed a right-sided ear infection soon afterwards. The patient advised it took about a year for both infections to fully resolve, at which stage he had severe swelling around the face and head, and at this stage they visited the hospital. Ever since, the patient has been experiencing stickiness and popping in both ears when he blinks his eyes and swallows. Doesn't report any hearing problems per se, or vertigo, or he didn't have any upper respiratory tract infection, which can cause obstruction of the eustachian tube. So when I examined their ears, it was clear of earwax, but the skin lining their left auditory canal was broken and macerated. Although both eardrums were visible intact, the left was opaque in appearance, and there was also a mild attic retraction in that ear. I performed a middle ear test which showed normal middle ear mobility, so the eardrum was vibrating within normal range. There was some negative middle ear pressure present, which can sometimes indicate some problems with the eustachian tube, but it was within normal range. However, when I perform tuning forks, so tuning forks is, you've got two types. You have a Weber, where you position the tuning fork on the forehead, or some people can do it on their front two teeth. And we would normally expect the sound to be centrally heard. But if it's heard louder in one ear, you've got to either suspect a conductive hearing loss in the ear that they heard it louder in. That's where the sound can't travel through the ear canal or the eardrum, but we know this patient's ear canal is fine. Or some hearing loss to the organ of hearing or the auditory nerve in the opposite ear, the contralateral ear. So they could hear this in their right side. And also we do another tuning fork test where you position the tuning fork in front of the ear, so it's heard by air conduction, so the air travels to the ear canal through the eardrum to the organ of hearing, and then you position it, well, you actually position it first behind the ear on the mastoid bone, so that's bone conduction. And you should normally hear the tuning fork louder, that's called the Rene test. You should normally hear that louder when it's held in front of the ear canal and not louder at the back. And if you hear it loud on the bone at the back, so bone conduction, it suggests again there's some obstruction to the ear canal or middle ear. So on the right side, they heard it louder when we held it on the bone as opposed to the ear canal. So we call that a negative Rene. But on the left side, it was positive. So they heard the tuning fork louder in front of the ear, so the air conduction as opposed to bone conduction. I tested for pathology cessation tube and a third window syndrome, and that came back negative. So because of, they mentioned they get some stickiness in the ear when they swallow, and although, the middle ear test did show some negative middle ear pressure, but within normal range, I still suspect there's a possible underlying eustachian tube problem there, particularly because there was a bit of an attic retraction as well. So we recommended some nasal steroids, but because of the results of the Weber and Rene, I explained to the GP I suspect there's a conductive hearing loss, and so this patient only attended for an earwax removal appointment. But based on those two tests alone, this patient needs to be seen by ENT. So anyway, I wrote the letter to the doctor. I was quite comprehensive, I felt. And then received the letter back. Doctors having to go at me, says, well, why didn't I refer directly to ENT? And I was like, well, it was quite condescending, the letter, stating that I was breaching my duty of care, and it took me back a bit. And I can't refer directly to ENT on the NHS. We can refer to, if the patient wants to see ENT privately, that's a different matter. But I don't work for the National Health Service. There's no means for me to make a referral to ENT, secondary care, directly myself. That has to go through the GP. And that's our criteria, and that's our guidelines. And the GP was fully aware that I'm private. I don't know how I got onto that story. It was something to do about, this patient may wish, I can't remember why I got onto that, but there is a link if you rewind, there's some link, but as you guys know, sometimes I do go off on a tangent. Yeah, so we just politely, probably the doctor's having a bit of a bad day, just wanted to vent their anger. So just replied politely, just explaining that unfortunately we can't make direct referrals to the ENT via the NHS, because we are completely private. We are not an NHS service, and then there's all the funding, and there's a lot of behind the scenes stuff that happens there. So that has to be done by the GP, hence why we refer to the GP. So more or less done. You can see this is where the erosion is. Just entering it again, just to clean up a little bit more, just to the right here. So again, we're really careful not to make direct contact with the bony part of the ear canal. I should have, guys, I think I'm allowed to say now, I'm going to be appearing on the Rachel Cruise show next Monday, the 28th of April. It's going to be between 3 and 4 o'clock Eastern time. So in the UK, that's 8 p.m. It's going to be on Facebook Live. It's a live kind of podcast. I think it's about half an hour to an hour. I'm not entirely sure. So we did our kind of mic checks the other day. I didn't realise the complexity of Facebook Lives. Rachel Cruz's producer kindly logged on and made all these adjustments to my Facebook. It's way beyond my capabilities. So I will put something on social media soon. I'm just waiting for some advertising images from her producer. But you can see that widening there. I suspect it's possibly some benign osteonecrosis or previous external auditory canal cholesteatoma, which has since healed and been treated, and the skin's re-epithelialized. And you're going to look, hopefully you'll see it, I'm going to look into the autoatecotomy in a moment. So that's the eardrum, it's quite opaque, and then even getting the endoscope to look into that posterior superior quadrant where there's the autoatecotomy is quite challenging, but you will see it in a moment. So just want to see if I can clear a bit more here. So again, that's that narrow section, and then it's just a bit of fogging, so I'm just going to clear a bit more debris, then we're going to have a proper look. So that's that region there. The bone is missing, so you can actually see into the middle ear. You can see the neck of the malleus, part of the head of the malleus. You normally can't see those structures now. There might be some keratin buildup in there, but yeah, I just want this patient to see ENT, just to have a proper examination, just in case anything sinister going on. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.